the female temple, guys, do you think it should be either concave, flat, or convex?
Let me do a poll here.
Okay.
Concave, flat, convex. Apparently nobody has a clue here.
They're all still waking up.
Yeah.
All right, but listen.
Why don't you explain this?
Yeah, think about the male patient, okay? The masculine male who has a dominant and a well-projected and defined face, he should have a strong facial musculature, because imagine the caveman goes to he goes hunting, he takes an animal, he rips the meat off the bone, right? He should have a strong masseter, he should have strong temporalis and strong pterygoids, therefore it should be projected here. So the male temple should be convex, and the female temple, therefore, it should not be concave because that's unhealthy, it should just be flat. So this is the end point for our temple. So there's always a rationale for what we're trying to achieve and where we should stop. Camera, please. Just zoom, thank you. Now, look everybody. She has now a beautifully elevated eyebrow with a wonderful tail extension. This tail is hiding into the fossa. And this eye now looks a lot more awake. She looks a lot more happy and rested as a result of that.
Raj, you see also in this from the audience, you can see that perfect. So the eye is more open than the other eye. It's very obvious.
You know, one thing that's really interesting about this, Kurt, is that when you do this kind of technique, you start to realize just how deficient the other side was. Because if I sit forward like this, you know, I always talked before in the theoretical part, the eyebrow should be 12 to 14 degrees. The canthal axis should be 12 to 14 degrees. Look on this side. She has a negative canthal vector, and it makes her look sad and tired. And then, when you correct it, it just all of a sudden restores the perception of health. Let's go back. So now we're going to go to the zygomatic eminence, so we're going to stay with Voluma actually, because she's quite deficient here. So I was past the 0.2, we probably need a little more, so we're going to do a fresh one here. Okay, so
there's a question, Raj.
Yeah, please.
I'll rephrase it.
Dr. Akina, this lady, she is young, and you are putting small points in specific areas, and it's making a big difference. What about a lady in her 40s with more redundant skin and ligaments? Are we going to increase the points or the volume?
Everything. I don't know if you were in the lecture yesterday, and I did 20s, 40s, 60s. The 20s is cheap. The 40s is average spend, 60, you become expensive. So she needs more volume in more points. Okay? When you have redundant skin, the redundancy of the skin is actually relative to the poor support of the facial skeleton, and therefore she needs more skeletal support, which means that she needs more voluma on the bone. Okay? Therefore she becomes more expensive, but more quantity, but also in more points.
Another question. When is the stage that you tell the patient fillers are not eligible for you? You should go for now.
You know, 5 years ago, I would have said there is a patient like that, but now, and I think I showed the slide of the 73-year-old lady, she was completely surgical, and she got a result. Because now, I think, because of the technological advancements of stuff like this, and also the advancing injection techniques, we can make results in pretty much anybody. Yeah.
Also,
how long will be repeated?
I do an annual injection. Yeah.
on the other hand, if you start early,
Yeah, exactly.
you start early, you get a build up. So it was not so wrong to start with a 25-year-old Sally earlier this morning. If we continue doing this, she will never need a knife.
Okay, so let's move to the next point now. So she has a slight male amount which is exacerbating the appearance of a tiredness. Do you have a puffiness here when you wake up in the morning? Puffy? No, she doesn't. So I always ask that question because if this patient has puffiness here, then I'm very cautious about loading the medial cheek, just because it could end up bulging the male amount a little bit more. So this is the male amount, and here, I don't know if you can see, but at this point is the cutaneous insertion of the zygomatic retaining ligament. Come forward and bring your head down, 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 down. You can't see it so much on this side, it's very interesting, because of the 2 points that I've done, she already has almost a full correction of the tear trough, whereas on this side, can you see? She has the tear trough with the extension through the mid-cheek, and this is the cutaneous insertion of the zygomatic retaining ligament. It's a really nice way to show a result when you've only done such minimal work. Let's go back. So what I do now is, I'm going to retract the skin because I want to inject the product just medial to the zygomatic retaining ligament, so that when I release the zygomatic ligament, it falls onto the voluma. And that means that we have a structural, like a support for the ligament. So again, retract, I go down, and I have to make sure I get to the maxilla here, because if you're not on the bone, you're not able to give structural support. And that's very important. There's the aspiration. It's very important with a patient who is suffering with maxillary hypoplasia. You see, if that's the disease, then the cure of the disease is structural correction. So I need to be on the bone. Okay, so I'm going to inject 0.3 cc. And then this molding is slightly different. It's more purposeful, and also it goes in a different direction. So the product is here. I take the material, and then I'm going to mold it upwards towards the tear trough, and also towards the medial cheek. And what's happening is that this voluma, because it has a low molecular weight and it is very moldable, it slides against the zygomatic ligament and it supports it all the way up. So then what we should start to see now is also lower third changes. Let's take a look at this. So, straight up, thank you. Now look at this, so beautiful. She starts to get a lower eyelid, which is beautifully supported here. Look guys, this girl has got scleral show on this side, and you only see this scleral show now when you start to correct all this stuff. Look at the corner of the mouth, it's already chasing up towards her left ear. And if we now look at the jawline, even at 24, can you see? She's jowled. And on this side, she starts to become more vertically lifted. And that's because she has got excellent soft tissue integrity. And so her responsiveness to voluma is very, very high. So take these 24-year-olds and inject them for structural support. They don't need it, but she's benefiting from this in the next 10 years now. Okay, let's go back. Now we're going to keep with the voluma, remember? We're going to go to the jawline and the chin. Thank you. So the next injection here is going to be, sorry, lift up, good. If I want to influence the jaw, then why not start here, okay, for this kind of effect? So I don't want a projector, I just want to support it. So your volumes have to be low in these younger patients. Turn this way, thank you. I don't know if you can see on the, yeah, you can see on the camera. There is a lack of interest to this area. It's kind of blunt. It's not as attractive as it could be. I think that when we have a really beautiful lateral jaw, what we see is quite a clearly defined preauricular sulcus with a very defined angulation here at the mandible, which should conform to 94 to 100 degrees in a female patient, aesthetic ideal. So we stay with the voluma now. I pull the skin back of the jaw. I show the posterior radius of the mandible. And what I'm making is an L-shaped frame. You see I'm creating a frame in which the product is retained in. I go down at the apex of the angle, touch the bone, sorry, the periosteum. People just don't like that B word frame.
No, exactly.
Yeah. Okay, so we go slow. 0.2. In fact, I'll just do enough so that I can see the projection.
I sometimes use the term osteocytic mass.
Yeah, then no one knows what you're talking about. Okay, so now I'm going to mold this in, and I'm going to conform it towards each border, so the posterior and the inferior border of the angle of the mandible. And then, when I take my finger away and I mold like this, you can see that she has a much more sharply defined angle, and also it generates a little bit of this preauricular depression, which is very beautiful. Do you wear your hair up or down? Do you wear your hair up or down? Do you hair down or up? Okay, good. You know, sometimes When the girls are wearing their hair down all the time, well, you don't even see this anyway, but the minute you do this to the female patients, they start to scrape their hair back and show off the jawline because it looks so beautiful. Okay, now we're going to do the pre-jowl sulcus. Staying with the bloomer again, thank you. Let's change this. Really important that we have an accurate definition of where we're injecting. Sorry, I'm going to just explain what the purpose of me injecting here is. She doesn't have jowl, or she doesn't have a depression or a notch. It's because she has got a sad mouth. That corner was aiming downwards. That means that the weak mandible is allowing the mentalis and the DAO to become hyperactive. The DAO is pulling the corner of the mouth down. So to support the DAO, I have to inject in behind it here onto the periosteum, project it forwards, myomodulate the muscle, allow it to release so that the midfacial elevators can become more dominant. Do you all understand that process?
You get it?
Okay, I'm assuming they're nodding their heads there.
Yeah,
Okay.
definitely. I'm nodding.
I mean, this is a relatively new sort of way of thinking, but you know, it's a way of dealing with causality as opposed to symptom. So we inject then onto periosteum, and you've got to be medial to the mandibular retaining ligament. If even a single drop of product is injected lateral to that ligament, it's going to occupy the space of the jowl fat compartment, and it's going to make her look more heavy then. So look at the orientation of my needle. It's from lateral to medial. So, look, she's only young, but she can take up to 0.3 here.
Raj, this is perfectly in line with what I did earlier.
Yeah,
So
absolutely.
from the small one, this is a small chin and a pointed chin, from
Exactly.
inside out, and
Yeah.
you want to make it more pointed. So you
Yeah.
go from outside towards the inside.
Good, that's a great point. And you know, one thing I noticed when you did this, Kun, is that you were, whilst you were injecting, you were retaining the material. Yeah, and I love that technique. But you know what I do? When I do this first, and then afterwards, I take my 2 index fingers, and then I trap this stuff. So what I'm doing now is I'm forcing that material to be squeezed into the inferior border of the DAO against the jawline, so that I get a straighter jaw, but also have a greater impact on weakening that DAO muscle. So once I've done this, I call this like a high definition jaw. Do you see the effect of this now? It's very dramatic. Sit forwards.
Wow.
Look, everybody. The corner of the mouth now is starting to go up even more. Okay. Show me a big smile with the teeth, please. There you go. Look at this. Do you agree with me, everyone?
Yes.
So
Even,
obvious. So
even though
obvious.
she's smiling,
Yeah.
she is still not happy here. Okay. This is a genuine happy smile now. Okay? Only by this one point. Let's go back. We stay with the voluma and we go into the lateral labiomental crease, because look what I did here. I created a beautiful straight jawline. However, reciprocally, I'm creating a depression in the labiomental crease. And in doing this depression, there, you see this, this extension of labiomental crease as it runs laterally all the way to the mandibular retaining ligament. In creating that depression, I'm actually generating a target for my next injection. So this injection has to be behind the DAO, so you need to be in the submuscular plane. I would advise that in this location, you don't touch the bone, because you have got the mental foramen sitting just in front of you, and it can be uncomfortable for the patient. The other thing is you don't want to end up with a hematoma or something here, which we often see actually in this location. So nice and slow injection. And this product will be molded immediately. You'll notice that with my injection technique, the molding is playing a very big part in the overall result. So it molds immediately like this, away from the ligament. And then now I'm going to connect the lateral labiomental crease to the midline. And look, I'm injecting more superficially. This is a subcutaneous injection. And the reason for this is because you have the gingival sulcus here, so that you have the mouth, right? So you don't want to put it there for sure. Okay, sit forwards. And look at this now. Look who has arrived now. So she is completely happy on this side. Let's look at the effect during animation. Show me a big smile, please, with your teeth. There you go. Beautiful. And look at